There's so many.
I was like, that packaging looks suspicious.
Oh, yeah, I'm sorry.
Don't say anything.
I got you.
But you do have the number 3, yeah?
No, we don't.
No? None of them?
Just one and two. So did you see the path announcement? Yeah. How many, I wonder how bad everyone did. We tried to look at Well, yeah. It won't show. Oh, yeah, it doesn't have the average ones.
No, she's putting in very big ones. I'll take that. I'll take that. I missed the spot shaving.
I think we're like pretty small.
I would need this. I don't know. Yeah. I'm very grateful for this class.
So you don't have none of them?
We have one and two.
You have one and two, the number 2.
Okay.
She said one minute I started showing you. Oh, yeah. That's the setup.
Oh, yeah. I was
Just dartboard.
I missed like 3 of like the clinical questions.
I missed one lecture and 3 questions. Was that Wednesday lecture? I thought it would be on Wednesday.
I don't know. It's going to be recovery. Yeah.
I thought we had like anesthesia or something.
Yeah. Okay, yeah, maybe.
So I didn't show up. We had something at 9.
Yeah, we had a really good schedule.
Yeah, we've done the I just slap it on the case. And then I'm like, wow, I'm burning a little bit.
Oh, wait. From here? Yeah. Oh, yeah. Sorry, here.
Okay, so I think it's time to start. So you know that today we will finish at 9:30. You do have 10 minutes break at 9 o'clock. You do have lots of slides, but most of them either I presented before or I can cut them down. So in general, we will talk about classification of periodontal disease. Before starting, I'm giving you an overview what I will talk about. In classification of periodontal disease, the recent one is 2017 classification of periodontal disease. The previous one was done in 1999, and the one before that was in 1989. Basically, classification is for what? for having the same entity with different characteristics. We classify. Even periodontal disease is under what? Under disease, under infectious disease. So in other words, classification, you can go far back. It's classified. Again, disease and health. That's another category. So about classification is like that. Now, the thing which I will talk about that. Periodontal disease, before that we talked about periodontal disease is what? Is infectious disease first, and then we do have different type of periodontal disease. Gingivitis is what? Is the disease which doesn't involve attachment apparatus. Water attachment apparatus, I talked about that. So you know that. Then we do have periodontitis. Periodontitis is disease, in other words, infectious disease which involve attachment apparatus, which is what? Cementum, periodontal ligament, and alveolar bone, together with gingiva. Therefore, when we talk about periodontitis, it means that we have loss of tissue. Gingivitis, we don't have loss of tissue. Now, in periodontitis, we know that junctional epithelium apically migrated. In gingivitis or health, it is not migrated. You see, these are all the things which we talked about that. And I'm just going over that so that you remember that's the situation. Now, in classification of periodontal disease, in the past, they used different term for periodontitis. Now, 1989, they used adult periodontitis. In 1999, they eliminate the term adult, they use chronic periodontitis. Now, in the present classification, which is 2017, they are eliminating both of them. In other words, they put it under periodontitis. And then it has three categories, periodontitis, which we will go over that. But basically, I'm giving you an overview of what's going on. Now, in the previous, yes?
Do you have that lecture that you're going to give?
Yes, I have. But just now, I'm giving you an overview, what are important.
Okay.
Then I will go to that, because there are lots of slides, and you don't need to have all of them. But for remembering, I put it over there.
Okay.
Okay? Now, any other question? Any other question? Okay, so this is about classification. Now, this topic, in other words, this topic which you see, classification of periodontal disease, is from 4 chapters. In other words, you buy one, you get what? 4. Okay? This is the situation. Now, why 4 chapters? We are using classification. We use 4 chapters because in order to get to the disease, to the classification of the disease, we need to do certain things to get to the diagnosis. In other words, in this place, we need to go to diagnosis. But why we want diagnosis? Because diagnosis will tell us what to do, what to treat the patient. Therefore, in order to get to that, we need to assess clinical finding. What clinical finding? Periodontal clinical finding. Now, it is composed of what? Of gingiva or periodontium and teeth. These we need to assess. Now, in assessment, we do have clinical. Under clinical, also they put what? Radiographic finding. All of these we need to assess. Why? Because we need to come to a diagnosis what situation we have. First of all, are we dealing with health or not? And if it is not, which kind of disease? Gingivitis or periodontitis, which we know both of them are under the term periodontal disease. So this is basically like that. And why they use color classification? Because they want to make things easy to categorize, okay, this situation is under this condition, we usually go this way. So it makes life easier. So this is the basic thing. Now, going into the discussion, let me see, what should I do? Yeah, classification of periodontal disease, this is the first one. Now, second one. Okay, this is overview. So I can skip these things because it categorizes the disease and so forth. Now, the proposal of classification. Okay, so let me see why this is. Okay, David, tell me, let me see. So this one is going forward, yeah? Okay. No, and this is backward.
Yes.
Okay, good. So, basically in classification, we need to know whether there is health or disease. This is the first question. Now, second question is which kind of disease? And then third question, we need to come to a diagnosis. So that's basically what we want to do. Now, in order to do, we need to do, to assess different things. Now, let me see. This doesn't work. Okay, I think I should come here. Okay, so 1989, this is the classification. Basically, 1989, you should know just basically what's going on, which I told you. They classified adult periodontitis. Now, before that, at the beginning, the classification was what? Schmutt-Pyoria in the old textbook. You will go over there. So it goes back, but they start from 1989 to put it in your book. So you do have it. Now, 1999, they classified gingivitis, periodontitis, then adult periodontitis gets chronic periodontitis, aggressive periodontitis, which you should generally know. Now, and the difference between 1989 and 1999, generally you should know what's going on, the difference. Now, then I talked about gingivitis, periodontitis before, so I'm not going over that. I'm skipping these now. Disease system, what we call right now is what? Disease system, and why it is important to do classification, because we need to communicate with other people, we need to do prognosis, we need to do treatment plan, so we need to classify the disease, and according to that we know what to do. Now, according to the new classification, which is 2017, they classified into health, into gingival disease, which they classified as biofilm related, and then the one which is without biotin related gingivitis. Now, next one, this is what? Classification. Basically, this is the new classification. So in other words, we do have periodontal health. Periodontal health can be on reduced periodontium. In other words, when you treat the patient and then you control all the etiologic factors and you see no bleeding on probing or the other criteria, then you do have health. So it will be health on reduced periodontium or health on intact periodontium. Then we do have gingivitis, which they categorize, they sub-categorize to these three different things. And then gingival disease, which is non-dental biofilm induced, which there are different categories of disease which comes under this area. So, and even neoplasm is coming under this area, gingivitis, if it shows on the gingiva. So now on any one of these, if you want more information, let me know. Otherwise, I will go fast because it is self-explanatory. Now, okay, so in this category, in other words, 2017 category, classification of periodontal disease, they also include one part about implant, which they subclassify into peri-implantitis, then peri-implant mucositis. What's the difference between peri-implant mucositis and peri-implantitis? In peri-implantitis, the bone is involved. The bone has been resolved around the implant. In peri-implant mucositis, the bone is intact. So this is the difference, and also there is some deficiency in the implant area, which they categorize as peri-implant soft and hard tissue deficiency. So this is the extra things which they put in 2017 classification. Now, in order to get to this classification, there are, you can see, lots of periodontists gathers, and then they sit down in different sessions, and finally came to the conclusion that we eliminate adult periodontitis, we eliminate other things, and we put just periodontitis. And the reason for that they stated. Now, before that it was, juvenile periodontitis. Then in 1989 we do have juvenile periodontitis. Before that there are different things. So anyhow, right now they come to this conclusion. Now, this is overview what are called diagnostic question. There are 3 questions in order to get to diagnosis, which it is stated here. And the question are, what does the clinical assessment indicate? Health or disease first. Health or disease. In other words, we need to do clinical assessment. How we do clinical assessment? We get information from the patient. Information from the patient we get, how we get. We examine the patient. Now also we ask the patient. These are gathering the information. Now, first question is health or disease. Then if it is health, okay, that's it. If it is disease, then which kind of disease? Gingivitis or periodontitis. And then which type of gingivitis, because it has subcategory, and which kind of periodontitis. So now, then sign of inflammation. Sign of inflammation in the periodontium. Either you will see it is overt sign, which you can see by your eye, which is what? Contour of the gingiva, form of the gingiva, texture of the gingiva, color of the gingiva. These you can see. Sign of inflammation. Now, if you see it is more red, you know that it is inflamed. Now, hidden sign are what? Those things which you can't see. In other words, when you do bleeding on probing, then you will see bleeding on probing. So that is hidden. So remember, hidden bleeding on probing is not overt sign for inflammation. It is hidden sign. Now, bone loss, again, it is hidden. You can't see it. You interpret that, okay, this X-ray bone should be over here. It is down, so it shows signs of inflammation. Now, okay, so in this classification, what they did for determining the severity of periodontal disease, before that, in 1999, in order to define the severity of periodontal disease, they used the term mild, slight, moderate, or severe. They eliminate that term. They, instead of that, to show the severity of periodontal disease at the present time, from 2017 classification, we use stage. We do how, and the stage defines the periodontal disease. It doesn't pertain to gingivitis. So when we say stage, we mean what? We are talking about periodontal disease. Now, stage 1 is the initial, in other words, it is 1 to 2 millimeter attachment loss. It will be stage 1. Stage 2 is moderate attachment loss. How much is moderate attachment loss? You see, these will go 2 by 2. In other words, 1 and 2, we call it slight attachment loss. 3 and 4, we call it moderate attachment loss. From 5 onward, we call it severe attachment loss. Now, stage 1 is when you see 1 and 2 millimeter attachment loss on any tooth which has periodontitis. Now, right now in 1999, the way we define periodontitis, we went after every tooth and we saw where we have attachment loss. We measured that, then we saw if most of the teeth had attachment loss. We were dealing with generalized periodontitis Now the type, we put either slight, moderate, or severe. And now we don't use the type slight, moderate, severe periodontitis. We use stage. So, and the difference is like that. Right now, in order to determine whether the tooth has periodontitis or not, we use bleeding on probing. When we see pocketing, which is 4 millimeter depth and more, and also at the same area, at the same location, we see bleeding on probing. We term that tooth as periodontitis. So remember, periodontitis by 2017 classification is tooth which has pocketing. In other words, if you do have a tooth which has recession, severe attachment loss, but there is no pocketing, you can't get 4 millimeter depth, and but it is bleeding also. It is not called periodontitis. Periodontitis by 2017, it goes after pocketing, which is 4 millimeter depth, and more, and bleeding on probing. Now, today what we do, we see which teeth are have 4 millimeter depth or more, and at the same point with 4 millimeter depth or more, bleeding on probing, we count them. Those teeth are teeth which are qualifying teeth. In other words, those are teeth with periodontitis. The other teeth, which they don't have pocketing, and even if they have a bleeding on probing, they are not considered as periodontitis. Then we will divide the number of teeth, which those criteria, which are what? 4 millimeter depth or more, pocketing, and bleeding at the same point, not bleeding on the same tooth in some other area with shallow pocket. At the same point, we count them. Then we divide by the number of the teeth which is present in the mouth. If it is more than 30%, and then times 100. If it is more than 30%, it is what? It is generalized. If that number is less than 30%, then it is localized periodontitis, and after that we use stage. In order to determine stage, we check all those teeth with those criteria, 4 millimeter or more, and bleeding at the same point. We need to measure attachment loss on those teeth. So in other words, right now the students need to measure attachment loss on each tooth which has pocketing, irrespective of bleeding or no bleeding. That's the criteria. Now, we go over there. If it is more than 30%, it is generalized. If not, it is localized periodontitis stage. Then we need to determine the severity. We see the teeth, the tooth which has the most attachment loss with those criteria. In other words, pocketing and bleeding on probing. Then that will determine severity. In other words, if in the mouth, on the rest of the teeth, you do have just 2 millimeter attachment loss, but in one point with pocketing, you do have 5 millimeter attachment loss, then the stage will be what? Will be stage 3. Stage 3, no, we are not using localized stage. It will be stage, that's it. Now, localized, we decide, first of all, periodontitis. Then, periodontitis without considering stage. If it is localized or generalized, then we go after the tooth with the worst attachment loss, and that will determine the stage. So in other words, in this case, it will be stage 3. Stage 3 is when there is attachment loss of 5 millimeter and more. Now, stage 2 is attachment loss of 3 and 4 millimeter. Stage 1 is attachment loss of 1 and 2 millimeter. So this is very important. That's why I am spending time on staging, because now when you get when you see those charts, then you will see stage, and then you should know why they put stage, for example, 3, and what's the difference between stage 3 and 4? It's the same thing, stage 4, but it is those teeth which are compromised, they can be go for extraction, or if there is posterior bite collapse, or if there is flaring of tooth because of periodontitis, or if there is 20 teeth in the whole mouth because of periodontitis, the patient has lost so many teeth, that will be stage 4. So when you see stage 4, then you need to know why it is stage 4. So,
Archie,
yes,
when you were saying it says 30% or less,
yeah.
and you said you have 1 tooth, isn't that less?
Okay,
Localized?
30% or it will be localized, yeah. 30% or less is localized.
Because, yeah, one of the students had said localized, you said not localized, so it is
Yeah,
localized.
no, it's localized.
It is localized.
Less than 30%
Okay.
is localized. More than 30% is generalized. Actually, this comes from what? When you divide, according to the mathematician, if you divide into 3, it will be 1/3 of the side. It will be 33%. But they use 30%. Yes, what's your question?
Oh no, I was looking. You said, I know you said it was from 4 chapters. Maybe I came in late. But what chapters are those 4?
Oh, what chapter? Chapter 4, chapter 10, chapter 20, chapter 21. Now, 21 is about radiographic finding. Now, chapter 4 about classification, which is a short chapter. But, I mean, the main thing is this one, this chapter. And then it comes for assessment, and after assessment is 4. Then what we do? What we do these things for? In order to get to diagnosis, and then to treatment. We talk about phase of treatment. In other words, in treatment we do have 4 phases. There is actually one phase which is before phase 1, and that is what? Assessment and urgent care. In other words, you assess, that phase is called assessment phase.
So it's
So, yes.
4, 10, 20, 21.
Yeah, 4, 10, 20, 21. Those chapters. And go over those chapters. They are okay. They are good. And you need to know that. Now, as a hygienist, you don't need to know all of them. But it is better to know. Dental students, they have to know that. Because they need to come to diagnosis. Now, you should know why they come to this diagnosis. And why they do that. Now, since I talked about phases of treatment, we do have 4 phases. Phase 1 is what? Is called non-surgical periodontal therapy, which in stage 1, different things they do. They do caries control. They do smoking. What do you do about smoking? In other words, for control of smoking. Then there are different things will be done in stage 1. But it is called stage 1. And now stage 2 is which stage? Is surgical phase. It is elimination of pocket. It is a correction of mucogingival deformities. It is extraction of teeth. That's stage 2. Stage 3 is what? Is restorative phase, which goes for what? Fixed prosthetic, removable prosthetic. That's stage 3 treatment. And stage 4 treatment is what? Which mostly you are dealing with that. What is that? Stage 4. Maintenance phase. In other words, they did, or you did everything, you control the disease after doing the rest of the stuff, which is stage 2, stage 3. Now, some people, they don't need stage 2. Some people, they don't need stage 3. But stage 4, they need it. And stage 4, usually, you master that because you maintain it. Now, so this is about staging. We do have also grading. Grading shows that how slow or fast the disease is going on. In other words, when you are monitoring the patient, in the maintenance phase. You will see, for example, in one area there is more bone loss. After how many years? 2 years or 1 year, it is slight. So then we go to grade A, which is slow rate. If it is moderate rate, will be grade what? B. And then grade C. Right at the moment in dental school, we are not using grade because the student don't have, but I think in hygiene, you can use grade. Because you do have most of the patient, you do have maintenance. How much maintenance space you have right now? You just started? Okay. So, yeah, there are maintenance space, and usually hygienists manage that. So, grading, I think you need to be aware of that before the dentist, because you will tell them, okay, dentist, here I got this problem. Pocket has increased from 3 millimeter to 5 millimeter. In how many years? In 2 years. Then he need to decide, okay, this is grade 2 or grade 1 or grade C or grade A. Depends on the rate of progression of the disease. So is it clear, this part? Because this part is important. This is the new part. We are using this one. So remember, we are using pocketing to determine whether there is a periodontal disease or not. And right now we do have health, unreduced periodontium. In other words, there is bone loss. You see bone loss, but you see health. And how we determine it is health? Up to 10% bleeding on probing. They consider it as normal. More than 10%, it is considered as what? Inflammation. So remember, if you see 10% or less than 10% bleeding on probing, you can call it health, gingival health. Now, it can be on reduced periodontium. In other words, it was periodontitis. It was treated. Right now, you have this condition. It is on reduced, it is healthy but reduced periodontium. Or it can be on what? On intact periodontium. So, this is one thing. Now, I talked about extent, which goes to localized and generalized, and how we decide and why we decide like that, because it is not just if you have half of the situation as periodontitis. No, 1/3 of the situation. If you do have periodontitis, which is what, 33%, which you can give discount, and it will be what, 30%, then it is called what? More than 30%, it is generalized. Less than 30%, it's localized. But in actuality, it should be what? 33%. Because those mathematicians, and the reason for that, actually there was an article, I don't remember what was that, because it was a couple of years ago. They came to the conclusion that we do localize and generalize because of 1/3 of the site. So, having said that, let me see if it's something else. Okay, stage and so forth. So this is example how they call localized stage 1, grade A, periodontitis and so forth. And then inflammation, sign of inflammation, no sign of inflammation. Health is no sign of inflammation. Now, what is sign of inflammation? What is sign of inflammation? Bleeding on probing. Then you see the color. Color which you see red. Texture, which is puffy. Gingiva is for puffy. Now, no sign of inflammation. You see none of them. Then you know that it is health. Gingival health. So, yeah. So this is, okay, the difference between sign and symptom. Symptom is what the patient complains. That's symptom. So in other words, patient will say that it is itching in this area. That is what? That is not sign, that is symptom. Sign is what you can detect it clinically. That is sign. And example, you have lots of things as a sign. Color, texture, and you name it. So So anyhow, okay, the main thing which differentiate gingivitis from periodontitis is attachment loss. Remember, it is not pocketing, it is attachment loss. And one reason which we ask students to measure attachment loss on each point which there is pocketing, 4 millimeter and more, is to realize attachment loss, to appreciate attachment loss. Because sometimes there might be no attachment loss, but pocket is deep. Because of what? Because the apical part in the coronal part of junctional epithelium is torn, or because it is there is edema in the tissue, so the tissue is coming up. So for that reason, the main thing which differentiates between periodontitis and gingivitis is attachment loss. So remember, this is very important. Now, so these I can skip. Now, okay, so I talked about phase of treatment, which we do out this phase. Now, you see assessment and preliminary therapy phase, it is not called phase 1. So remember, when we talk about assessment phase, it is not phase 1. It is before phase 1. Now, why they didn't put a number for that, I don't know. They could put stage 0 or whatever. Or now, so I talked about that. Now, next one, data collection. Assessment, in assessment and preliminary therapy, data collection will be, you use data, in other words, you collect data. What data you collect? Different things you need to collect. What are those things? About gingiva, about color, about texture, about consistency, then probing depth. These are all data collection. For probing depth, recession, if there is recession, attachment loss, mucogingival condition, then you name it, plaque, presence of plaque, calculus. These are all data which you need to collect. And even dental student also, they need to collect information about occlusion, which you don't need to do that. But you should know, but I don't know why it is not here. There are different things about occlusion, they need to collect it. So also about teeth, you need to put, to get data, what data you use for teeth, for periodontal assessment. What data? Easy. Tooth mobility is about tooth. Fremitus is about tooth. Now, detection, furcation detection, it's about tooth, okay? And you name it, other things. So this is, in this phase, which is assessment, data collection, you need to collect all these data. Also, local contributing factor. What are local contributing factors? Like what? Like calculus. It is local contributing, like overhang filling, like ill-fitting denture. These are all local contributing factor to what? To periodontal disease. So remember what we are talking about. So in this phase, which is phase 0, or it is not named 0, but it is phase assessment and data collection and urgent care. Urgent care, in other words, if the patient has a tooth which bothers the patient, they need to take care of that, or you need to take care of that. This is in this phase. We don't let it go pass by. Okay, we need to go to phase 1 so that we do after that. No, right over there, which is what? Before phase 1. Then, okay, these are, okay. In the last one, which is initial periodontal therapy, which is called also phase 1, which is called also, in this phase, what we do, bacterial control and anti-infective therapy. How we control bacteria? by oral hygiene and also what? Scaling and root planning. So this goes to this phase. In this phase also we do what? We do caries control. If a caries is going on a tooth and it might go to a pulp or something, they need to excavate and to put temporary filling. So I don't know whether you are allowed to do temporary filling as a hygienist or not. No, in some state I think they can. But anyhow, you can.
Like an extra.
Yeah, you are too busy. I know you are too busy with calculus. Yeah. Okay. So in this phase, these things will be done. So these are redundant. Phase 2 therapy, I talked about that, which is what? Which is surgical phase. Phase 4 therapy is what? Is maintenance phase. So you know that you have lots of maintenance phase. In this chart, it shows different, in other words, it shows treatment sequence. Now, so in order to get to treatment sequence, they need to do diagnosis. In order to get that diagnosis, what we need? What we need? You want to do a diagnosis for a patient. Patient is in the chair. What you need? No, data collection. So remember, data collection, which is before phase 1. You need that in order to get to diagnosis. Otherwise, you can't do diagnosis. In other words, you don't have evidence to say, okay, a patient, you do have periodontitis. But you need to collect diagnosis and to document it in the chart. So documentation is very important. So in other words, that phase, which is assessment phase, is very important. Why it is very important? Because it will guide you to diagnosis. And why diagnosis is important? Because it will tell the therapist what treatment is best for the patient. And why we treat patient. Why we treat patient. You see, you need to think about these things. These are very important. Why you treat patient? Exactly. You want to make the patient happy. Yeah, healthy, but basically happy, because the patient complain that I have this situation, and you find something else, and you explain, patient, you do have also this one. Then at the end, after treatment, you say, okay, patient, no more, you have this. Patient will be happy. I mean, you will be happy, everybody happy. Okay? Happy life, what was that? Happy life, happy patient, something like that. So remember, the main reason why you do something is what? You want to make the patient happy. Yeah, you want to eliminate the disease because the disease is not good. Why it is not good? Because it deteriorates. Therefore, it is not good. So remember, don't forget, the basic question, why you do something or why the patient is saying that I have this situation and it bothers me. Sometimes because of what? Spacing of teeth. A patient is not happy. So you know that's the main thing patient want, but there are other things you explain, okay, these things we need to do in order that orthodontists be able to do a good job for you. So then everything will be in order. So anyhow, in assessment, okay, these are, you see, I am repeating so that you remember. In other words, in this phase, which is phase what? Assessment phase and preliminary therapy, you do these things, starting from health history and ending to extraction of hopeless teeth. Okay? These are what? These are before phase 1. All of these things. So now, okay, again, this is redundant, this slide, because I talked about that. But anyhow, you need to do all these things, or all these things can be done in what? In phase 1, or non-surgical periodontal therapy. One of them is what? Is occlusal therapy. Is also in this phase. Minor orthodontic treatment is in this phase. So you remember. Okay? So in this phase, lots of things can be done. Fluoride therapy. Nicotine cessation counseling. are you required to do nicotine cessation counseling? I think hygienists need to do that. Do you have that course? Yeah, you should have, because hygienists are very important in cessation of tobacco, basically, and you should master that one. And in order to master, you should believe in that. In other words, you should know, okay, this condition caused so much problem for the patient. Let me discuss with the patient. And when it is from your bottom of your heart, then the patient will get it. Otherwise, they won't. So this is very important. Cessation of tobacco. So you see, these are redundant now. Periodontal surgery is next stage, which is what? Stage 2 is surgery. Now next, and then maintenance, which will be stage 4. Before stage 4 is which stage? Stage 3, yeah? Now stage 3 is what?
Surgical?
Is restorative phase. By restorative phase, we mean what? We mean that if the patient had temporary filling, now they can put permanent filling. Why we are not advising to do permanent filling in phase 1? Because the tooth might be extracted later on, then the patient is not spending the time and money on that. In this stage, after doing phase 1 and phase 2, which is what? Surgical management. Surgical management because of what? Because of what? In periodontic, why we do surgical management? Why? 2 reasons. One is those persons which have mucogingival deformities. Now remember, in this classification, we do have mucogingival conditions. Now, beside condition, which you should know what are those things. It is recession, it is excess gingiva. Different thing, they put it under condition, mucogingival condition, in this classification. Now, we do have also mucogingival deformities. Now, what are mucogingival deformities? 3 things, according to Dr. Goldman, which proposed, I think in 1930-something or 40-something, proposed, is what? High frenum attachment is mucogingival deformity. And these are what? These are contributing factor to periodontal disease. This is one, high frenum attachment. Next one is what? Shallow vestibular depth is the next mucogingival deformity. So remember, we do have mucogingival condition. According to the new classification, we do have mucogingival deformities. Deformities up to now, I mentioned 2. One is high frenum attachment. The other one, shallow vestibular depth. And the third one is pocket traversing mucogingival line. Now, where is mucogingival line? It is where the gingiva meets alveolar mucosa. Now, if pocket traverse that line, then we do have mucogingival deformity, and that mucogingival deformity is called mucogingival defect. So, when you hear mucogingival defect, you know that pocket traversed mucogingival line. Now, there might be very tiny bit of gingiva unattached, or no gingiva, or more gingiva, but when pocket traverse mucogingival line, it is called mucogingival defect, which is categorized under mucogingival deformity, which mucogingival deformity by this classification is classified under what? Under mucogingival conditions and other. You will see it like that. Now, which is classified under what? Under periodontal disease, which they divided right now into 3 subcategories. So, that's about mucogingival defect. Mucogingival deformity and mucogingival condition. So by now, every one of you should know the difference between mucogingival condition and mucogingival deformities. Deformities, there is 3. Mucogingival condition, it is more. I didn't count that, but you can count it. Okay? So, anyhow. Periodontal maintenance, so you know that periodontal maintenance is very important and it is ongoing. And you as a hygienist, you should be very alert and master that because you can prevent further damage to the tissue. In other words, you don't want to just watch something happening. Okay, now let me see how it goes more or not. That's not good. So in other words, when you detect something, you put it down in the chart and you discuss, yes.
What stage did you say the deformities were under?
The deformities are under mucogingival conditions which you have in this classification, 2017.
What is it, like a certain stage in periodontitis or?
Oh, no. This is, in other words, they categorize it under what? Periodontitis, but this is other things which you will have it.
Okay.
You see what I mean?
Yeah.
But it is categorized under periodontitis.
Okay.
But by now you know that periodontitis is what? Pocketing, 4 millimeter and more, and bleeding at the same area. Okay? So other things, they classified it, and actually you have a very good point. I need to go over that to see if it is getting that criteria. Good. So yeah, anything it seems that it is unfamiliar, let me know so that we make it clear. Because you see, these are repeating what I'm talking. And I'm repeating why? Because you need to remember that. Okay, these are now. Okay, so decision making. Yeah, after gathering all those data, then it is decision making. And why you do decision making, why you need to decide, because you need to diagnose and then to do treatment. Now, this is going to chapter 20, which is assessment. So assessment, in assessment, it is what? In assessment, we do have 2 situations in assessment. One is in-depth, which is called what? Comprehensive periodontal assessment. And the other one is not in-depth, which is called what? Periodontal screening assessment or periodontal screening examination. So in assessment, we do have 2 categories. You see, everything, there is classification in everything. In assessment, either we assess periodontal screening examination, which is a rapid situation which we determine if the periodontium is healthy or not healthy, and if there is a need, if it is healthy, there is no need for further treatment. If it is unhealthy, then gingivitis or periodontitis. So that is periodontal screening. Now, comprehensive periodontal assessment is intensive. You need to gather intensive information, more information in order to get to a diagnosis. So basically, that's about assessment, which we do have 2 types of assessment. Then they talk about baseline data. Now, 9 o'clock, 10 minutes to 9 o'clock. 9 o'clock, you do have 10 minutes break. So the data, when they talk about baseline data is what? All these things which you assess, which is from probing, depth, attachment, loss, and you name it. These are what? Baseline data, and this is very important. It should be very thorough and in other words, everything should be up to the point so that you can use it for future to determine how the patient is going. Now, why it is important to remember or to have it documented for the future. Why future is important? Yeah, we need to compare to decide whether there is other things we need to do or not. Okay? Why? Because the patient has no idea. And you need to let the patient know, patient, you do have this situation. And actually, I remember Dr. What was his name? He was talking that, okay, some patient, yeah, you talk, and you talk and talk and talk, and then they get confused. So the way, his way was like that. Patient, you do have problem, and I have the solution, and that's it. But that's not the way to go, because you need to get consent form, you need to explain to the patient. Patient should be aware. Actually, you should check whether the patient understood what you said or not, and then get consent. Otherwise, what's the use of consent? Patient will give a signature, so what? But the important thing is that to make the patient, to educate the patient. So one of your roles as a hygienist is to educate the patient about health in general, and especially about oral health. So this is very important. And it comes about when you believe in that. In other words, it is part of you. Then the patient will grab it. Otherwise, they won't. And actually, one of my teachers back then, whenever he said something, he will do exactly like that. If he say the patient, you need to brush 10 minutes, he would brush 10 minutes. And he was enthusiastic, and still I remember him. Why? Because whatever he said, whatever he taught us, he believed in that. He knows the consequence. So he went that. And one of his character was that he didn't like pocketing. In other words, he wanted to eliminate any pocket above 3 millimeters. And he will do that. If he couldn't, he will extract the tooth. But he was very mean. That was the way he will go. And the reason for that, because he will say, okay, patient cannot clean this area with this pocketing. Therefore, either we need to eliminate. And the elimination is what? Either by surgical management or by elimination of the tooth. Or he will go eliminate one root in order to eliminate the pocket. But that was the situation. And he was great, I tell you what. That guy had, his hand fractured, and he used to bring us to his house to give our lecture, and also every one of us also lunch and beverage. So that guy was something.
You should do that one.
Yeah, okay. Yeah, but the Dr. Korn, Herman Korn. And you will see in the old book, you will see his name, and her wife was, she was a very nice person. So anyhow, I remember him. Why? Because whatever he said, he believed in that. And he had, whenever I worked with him, I knew that whatever he said, that's it. And the reason, he will give you the reason why I don't like that. And that was it. And everybody will say, okay, Korn, when he say something, that's it. Now, so let's go standard of care. Standard of care is what? Accurate recording of assessment. That's very important. In other words, when you do something for the patient, that is the whole world you have. You need to make sure that you do the best for that patient. So this is standard of care. And how you get to that? Because you want the same thing for yourself. You don't want something mediocre. You want the best thing. So you do the best thing for your patient. Okay, that is the standard of care. Now, then we go about periodontal screening examination, which is a rapid technique which they do. Now, what they do, the example is periodontal screening and recording, which they call it PSR, and it has a WHO probe. the probe which they use for that, and the probe is marked what? 3.5, 5.5, 8.5, and what they do, they go into the mouth, they check, they go around the tooth, and they will see if they go to 3.5 or not, and if they will see the most, in other words, the largest number on the sextant, on that sextant, they go by sextant. In other words, on that sextant, the largest number, they will put it, that number for the sextant, one number. And then at the end, they will decide. If the number is 3 and 4, yeah, there is a need for further, assessment. So in other words, comprehensive. If the numbers are shallower, then there is no need for further treatment. So they determine. This is, a fast thing, which they use it in epidemiology. Now I think I do how, the way it goes. This is the probe they have, which is a WHO probe, World Health Organization probe. Okay? So the difference you see with our probe. The difference, no, you don't see here, but when you use your mind, then you see that. So I should be very careful when I talk, okay? Or better not to talk. So yeah, you see just that one. In other words, 3.5, 5.5, and they are half. Now, use of code, they use code. Now, code 3 or 4 indicates, it shows that there is a need for comprehensive periodontal examination. Okay? So basically, it's like that. Now, I think this doesn't want, yeah. Okay, so the component of periodontal assessment, I talked about that. These things you need to do are component of periodontal assessment, which start with bleeding or probing, with probing, level of gingiva, recession, and so forth and so on. So these I talked about. Now, in this picture, you will see different parts, which I gave the lecture before. So in other words, I can eliminate all these things, because before that, I went over that. Over attached gingiva, marginal gingiva, and you remember that, papilla, and so forth. It was a while ago. So in this picture, it will show now alveolar mucosa and so forth. Now gingival inflammation, either you see erythema, which is what? Which is redness on the gingiva, or erythema and edema. Edema is what? Swelling. Swelling, why swelling? Because the fluid came into corrective tissue of the gingiva. From where? From where the fluid came. You remember that the fluid, and then where it goes?
From the blood?
Yeah, exactly, yeah. And then where it goes? Gingival crevice, gingival sulcus. Okay, so you remember that. So I talked about these before, but in this chapter it's like that. Now, then relationship of gingiva to the tooth, which is either it is right at CEJ level, the margin of the gingival margin, or either it is above CEJ or below CEJ. So that's the relation of marginal gingiva to the tooth. Now, if it is below CEJ, you will see root, which is recession. If it is above CEJ, you won't see root. Now, in order to get to measure attachment loss, what you need to do, you need to go to CEJ area, see how much you went up to there. I think I do have a slide over there. So a normal position usually is where? Is slightly above CEJ. Now this is different area. Now this is above CEJ. Above CEJ. This is right at CEJ area. And this is below CEJ. You can see root. And also root on that tooth also. Now, it talks about recession, which by age you will see more recession. It is common to see recession in the mouth, at least one recession, two recession, or something like that. And the percentage they put it, Now, in order to classify recession, there is Miller classification. Miller classification they use, and then there is another classification which is by Chan and colleague, which they categorize to predisposing factor and precipitating factor. Now, predisposing factor is like the high frenum attachment, which can cause what? Can cause recession of the gingiva. Now, precipitating factor is what? Is like occlusal trauma, which will be precipitating factor. Now, Miller classification, Miller class 1. In Miller class 1, you see recession just, this goes to Miller class 2. Now, Miller class 1, okay, this is class 2. Okay, Miller class 1, recession is right coming to before mucogingival line. Okay, and interdental recession, there is no interdental recession. So this is Miller class 1. Miller class 1, no interdental recession, and then, it's 9 o'clock. Okay, so you have 10 minutes break. So I will talk about Miller classification, which is easy. So after 10 minutes, we do have 20 more minutes after 10 minutes.
You're saying that's class 1, but on the slide it says class 2.
Let me see. Let me go back. That's a good point. So this is class 4.
Okay.
So this is class 4.
Okay, yeah, okay. I was just letting you know.
Yeah.
But I guess you can tell them afterwards.
No recession.
Okay. Also,
Now, what's the question?
you were saying that it's important for people who need to stop tobacco.
Yeah.
What if the patient doesn't want to quit smoking?
Yeah, then you need to motivate. It goes to motivation.
Okay.
You need to know, in other words, you should be a good psychologist
Okay.
to see why the patient doesn't want. Maybe there is some problem in home or at work or somewhere. Then you need to go, in other words, as a hygienist, your role is, if you want to be good, you need to be a good psychologist also. Because that's a point. Yeah, some of them, there should be a reason why. Because
Dr. Parsi, turn off your microphone.
Okay, so, because some of them, they attempt it, and then they start because of something else. So, in other
My
words, it should be
my
a
mother has been smoking since she was 12.
Yeah. My friend's mom smokes a lot.
You see what I mean?
And she'll probably never quit. She's slowed down, but she's never going to quit.
Yeah.
And that's
then
just something
they
you have
will
to
say-
accept.
And I tell you what, some of them, they are smoking and they have no sign of, from lung or whatever. So they will say, okay, I'm like that. But you can say, okay, but it is not good for, the kids in the house or other things. You need to be concerned about that. The study showed, you see what I mean?
No, I know.
And then,
But
so in other words,
they
it
just
should be a
don't
good...
want to quit.
No.
'Cause
My mother and my sister
I have a
are like
friend,
that.
Her mom doesn't want to quit smoking. We tell her we try getting the nicotine patches, the gums, the little
I even
vaporizers.
I got that too.
And she doesn't want.
My sister's a nurse, and she doesn't want to quit
She's
either.
talking her pack of Marlboro.
So you need to make sure that you are okay with it. Because sometimes, because of the kid, you say, okay, let me get the pleasure of smoking.
I've gotten to a point where they're not going to quit. You've given them all the information you can, and you got to let it go.
Yeah.
Because the more you pressure them, the upset they get, and you gotta back up.
But you need to make sure that it is not good for the rest of the house. You see what I mean?
They all smoke outside. They don't smoke inside. But
Yeah, they
still,
will.
But still, the smell lingers. And then
of course.
Exactly. When they come
on their
inside,
clothes,
it's like-
on their bodies, but they don't see it. They don't smell it. They don't see it. But when you walk in, it's like,
and then she has a really bad cough. And
oh, really? Oh, that's scary.
They say, okay, this is bad
That's
cough.
very
It is
scary.
not, there is not some microbe in there. It's not good for us. So you need to do it.
I just wanted to know because I know some patients are stubborn.
Yeah.
They don't want to quit. They're
No,
stuck in
no,
it.
I understand that.
So I
Yeah,
just wanted to
very
know
good point.
what.
Very good point.
There's
make
only
sure,
so much you can
always make
do.
sure what's the reason behind it. You ask them, why you then what? They will say something, and then you try to motivate them.
Also, I went to the dentist a while ago, and he was doing like periodontal, like he was checking my gingiva, but he was counting it. He was doing like 1, 2, 3, or whatever. But he wasn't using a probe. He was just looking at my gums.
Oh, I don't like that.
So I don't know.
like
No.
I
that.
don't know what's that.
I don't know, because we do have a periodontal screening, but screening they need to use the probe, which is WHO.
He said it was a special form of gingival recession or something.
I don't buy that.
No,
I don't buy that.
Maybe he has something, for example, if he see inflammation, he put one.
But I mean, if you don't, if I'm thinking, if you, yeah,
But
you got to use the probe. I think you have to use the probe to actually have the definitive
yeah,
measures.
I think he was looking for like inflammation.
Yeah, for inflammation, exactly.
I don't think it was maybe pocket depth.
Okay.
Oh, okay. So we do have other things like papillary and marginal, but those are the indices which they use for general population. So I need to check that. Yeah, papillary,
I forgot the
marginal.
name of what he was, because I was sitting in the chair and I'm like, oh, how are you count? Like, because I thought he was doing probing depth, but he's like, no, I'm just doing gingival, maybe inflammation or something.
Yeah.
But
So
maybe with the papilla.
yeah, we do have
he was like- he was like
marginal,
1, 2.
papilla, and something like interdental. So maybe 3, it means that all 3 areas had inflammation, something like that.
Okay, because he was saying 1, 2, 2,
Yeah.
1, 2, and he was just saying like counting out the numbers to the other hygienist. I was like, well,
What's the other thing? Okay, so yeah, we do have these are for.
You should ask him. You should ask him.
I should have-
Can you tell me what you're measuring? I'm saying I'm a hygiene student. I'd like to know what you're
Yeah,
measuring.
on an epidemiological point of view, yeah, they do have indices.
yeah, they probably have like a bunch of different like ways to
But
measure.
right now we are not using those.
Okay.
So I need to check that.
Okay, yeah. I forgot what it was, but
It's good that you mentioned it.
yeah, because I just wanted to know because I know because he was a dentist, so I wanted to know what he was doing
Yeah, you should ask him.
versus the periodontist, where you're actually using the probe,
Yeah,
measuring the pocket.
Yeah, I think when it comes to the probe, you have to know the pocket depth.
Yeah,
You
yeah.
have to use the probe.
Yeah,
but
I think
you
he was.
never
I think he
know.
was referring to maybe gingival inflammation. He said it was like a
Possibly.
new, or not new, but like a different way of counting. I don't know.
So anyhow, yeah, but it should be something which other people know what's going on. But anyhow, the dentist knew what he's doing. That's good news about that.
Okay, Dr. Parsi, you got 20 minutes to,
Yeah, 20
to do
minutes, I'll
almost
finish.
100 slides. It's
Yeah,
not going to
I'll
happen.
finish.
So you got to decide which slides you want to present.
Oh, sure. So this one I will present, then the next one I think it goes to radiography, chapter 21, radiography and cellulography. Radiography, important thing is bone loss, then the rest, I will see how much time I have, and then we are done. But up to now, I covered chapter 4, chapter 10, and this is chapter 20. So 20 and 20.
Well, they should be arriving in 2 minutes to start. So
Yeah. So, so now I know how to put it on my desktop from thumb drive. I did it in the morning.
good.
It was at the beginning I was not successful, but after that I got it. So that was it.
That's very good. I learned how to take images or videos and put it on arc on canvas to give more space. So my canvas is very, very, it's 98% full.
Oh yeah? Wow.
So I've got to start pulling stuff off and getting rid of it because I'm going to run out of space. So that's what I'm learning how to do now.
So I'm reducing. For the next one I will reduce.
No, you're fine. I've got to go forward on. This is a PowerPoint. It's different than a movie video.
Okay, oh yeah,
Different.
yeah.
Yeah. Well, I'm going to get you lights situated because
So,
you could probably start shortly.
so you have 2 more minutes. Oh, 1 more minute. Okay, 1 more minute.
Okay, I'll be in the back.
Ask you a quick question, or
Yes.
you're about to start again?
In about 1 minute I will start. But if you have question, let me know. Okay. So, let me see.
Don't worry. Just talk to me. Just talk to me.
Ah.
Forget about that. Just talk to me.
Okay, sure, I will. No problem, no problem. So, the class is in session. Now, I was talking about recession. It comes to classification. Classification of recession. We do our Miller classification. Class 1 Miller. No interdental recession. Only direct recession. Which usually it is on what? On the facial side. It can be also on lingual side. Now, class 1 recession is when the recession didn't meet mucogingival line. In other words, it is away from mucogingival line. So that's class 1 recession. Now, it shows two type of recession. One is narrower, the other one is wider. Okay? So this is type 1. Now, type 2 recession. Type 2 recession, class 2 recession, is when the recession passes mucogingival line. It is class 2. Again, there is no recession interproximal area. But there is recession on direct facial or direct lingual. It is class 2 recession. Again, it shows two areas. One area is narrow recession, the other one is wide recession. Which in his classification, he didn't use narrow and so forth, but it was another classification from previous one, which used narrow, shallow, wide, and so forth. It was used those terms. Now, but we are talking about Miller classification. Now, then, class 3, we do have recession. Recession, which is what? Interproximal recession. And also on direct facial or labial of the teeth. So that is class 3 recession. And we do have one more class, which is class 4. Class 4 recession, you see the difference. So in other words, interproximal recession and also direct recession. Yes?
Did you say that class 3 was facial and lingual?
No. You see, it can be on facial, it can be on lingual. Okay? Usually on lingual, where you can see. Lingual recession, you can see on anterior, yeah? And on the teeth, on upper teeth, on maxilla. Which teeth you can see lingual recession? Usually those teeth which is what? Extruded or over erupted, which is what? Molar, which is because of what? Because of posterior bite collapse. The antagonist has extruded. Then you see recession is on what? Palatal side. Otherwise, they talked about what? Facial side. Why? Because facial side, patient can see that. Aesthetically is not pleasing. But back here, on lingual side, patient cannot see, will not notice, you will notice. So that's why they show it on facial side. Now, in class 4 recession, therefore, you see what? Recession interproximal. And also you see recession on direct facial. Okay? Now, what's the difference between this slide, which is type 4, and type 3? Now, in this slide, what you see, interproximal recession is not so much. But you do have direct recession, it passed the mucogingival line. Now, in type 4, you see actually, it is like in the same level or slightly more on interproximal area. You do have more recession on direct. Interproximal you have less, but they are near each other. And you see, according to this slide, in class 4 recession, you are not passing mucogingival line. But there is more recession in general, total. Why? Because there is more recession in interproximal area. So that's about classification of recession, which is Miller classification. Now, then we talked about these things is what? Mucogingival junction, which in the other chapter I talked about that. And then how we detect it. Usually you can detect it easily. There is difference between color. Sometimes it is not easy to detect. So you use an instrument, backhoe, some instrument like probe or whatever. And that area which moves is mucosa. It comes to a point which doesn't move. That is mucogingival junction. Then, okay, so these are about comprehensive. In other words, these are part of mucogingival junction. Bleeding or probing is part of what assessment. Then exudate. What is exudate? It is pus. What is pus? It is called also suppuration. Now, pus is what? Mostly it is a dead white blood cell. Why they are dead? Because they combat, and after that they will die. So they did their work, and then they die. Now, then that's about pus. Usually pus, you need to manipulate the tissue to see pus. It is usually yellowish material, which you will see. Sometimes you will see without checking, but most probably you need to manipulate the tissue. In other words, manipulate free gingival margin so that you get pus coming out. Now, you see, yeah, it seems that it is scared of me. It doesn't work. Now, then about tooth mobility. Tooth mobility, you know that you use two instruments. Buccolingual mobility, you check that. It is horizontal mobility. Now, we do have also vertical mobility. Vertical mobility, when we see mobility vertically, when there is more attachment loss, in other words, more periodontal ligament, when it is destroyed, you can see vertical mobility. Which it will be, when you see vertical mobility, it is class 3 mobility. Again, about mobility classification, we do have class 1, class 2, class 3 mobility. Class 3 is when you can depress it, or when you can see more than 2 millimeter movement in buccolingual direction, in horizontal direction. Now, class 1 is what? Is mobility of tooth. When you use two instruments, you tap one on buccal, then next on lingual, and you see movement less than 1 millimeter. It is type 1 mobility. Now, if you see 1 millimeter up to 2 millimeter, but not 2 millimeter, then it is class 2 mobility. And then we do have class 3 mobility, which will be depressible tooth or 2 millimeter, more than 2 millimeter movement horizontally. So you see that each one of these, it has classification. Recession classification, tooth mobility classification, and so forth. So, okay, so this is the way they do mobility, type 3 mobility, now vertical mobility, now class 1, class 2, class 3. Frematus. Frematus is what? Is visible movement of tooth when in function. In other words, when you ask the patient to close on the back teeth, and then you ask them to tap two together, you use your finger and you check, you put on buccal side of the tooth, and you will see if the tooth vibrate. You will feel under your finger. That's frematus. Now, if you don't feel it, there is no frematus. Frematus is important when the patient has occlusal trauma. then definitely you need to check for fremitus. So fremitus is movement of teeth in function, which is in maximum intercuspation when the teeth tap together, or in excursive movement when the tooth, you ask the patient to slide toward the lateral side and protrusive side. Now, so since I don't have much time, so this chapter is done. Furcation involvement to detect. Usually, clinically, you will first detect radiographically when it is more attachment loss in furcation. You can see on the radiograph, but and also this has classification. Furcation, we do have class 1, class 2, class 3. Usually on mandible, we do have 2 furca. One is on buccal, one is on lingual. Only molar teeth has furca. Now, in maxilla, we do have 3 furcation on maxillary molars and 2 furcation on first premolar in maxillary. Okay? So how we detect furcation involvement? We use neighbor probe. So you do have neighbor probe in your set. So, okay, so this was furcation. You will see like that. And then class 2, class 3, class 4. Now, other things like deposit, you need to assess deposit, which one of them is calculus. These are local contributing factor. Then local contributing factor is what? Restoration, which is overhang restoration and other things. Now, in detecting calculus, you know that you need to use your tactile sensation to detect it, or and sometimes you will see on the X-ray. When do you see on the X-ray? When there is, enough calculus, then you can see on the X-ray. So then local factor is important. Radiography. Now, in radiography, the important thing in radiography is what? Is to detect bone loss. In other words, to determine whether there is bone loss or not. This is very important. So I said that if the time is up, I can finish, but it is not, so I will come. I will go forward now. We also, so in other words, the thing which on the radiograph regarding periodontium, we will detect or what? One of them is bone. The other one is what? PDL. The other one is what? Which you can detect on radiograph. The tooth you can detect on the PDL. On the radiograph. And the other one is what? Restoration. You can detect it. What else you can detect? So we will go about vita attached gingiva. Why it is okay? So this is not okay. This is about mucogingival defect, which I talked about. Mucogingival defect. Now, 2 things we do calculate in getting those things are what? One is the amount of attached gingiva. We calculate it. How we calculate? We will see how much free gingiva we have, and then the whole gingiva, which is from free gingiva up to mucogingival line. We measure it. We will deduct free gingiva from the whole gingiva, and then it will be attached gingiva. The other one is what? Which needs calculation, is CAL, clinical attachment loss, or attachment loss, which we need to calculate. Now, how we calculate? This is how to calculate gingiva. In other words, attached gingiva. You see it shows free gingiva minus the whole total vital gingiva. It will be like that. Now, these are the things which in Axiom, if you use plus and minus to detect the free gingival margin, then you should know, but right now we are not using that. Okay, so there are other diagnostic tests which you can use, but usually we are not advising to use that, because by these assessments which you do, you can go to the diagnosis. So the different texts, one about deoxyribonucleic acid, one is what? Microscopy, which is phase contrast microscopy, which is good for teaching of the patient. Now this I don't know why it doesn't go forward. So anyhow, so now it's going, now radiographic. So benefit of radiographically and also the limitation you should not know. It will show a bone. You know that periodontal disease is a disease of bone. Bone you can see, only you can detect it by what? By viewing radiography. And usually we need FMX, full mouth X radiography to determine whether there is bone loss or not. Now, the thing which you will see on the radiograph are alveolar bone, periodontal ligaments, cementum, gingiva you can see on the radiograph. Now, then, okay. Now, then it comes that those area which you see on the radiograph, which is what? Which is bright, and those which are dark. In other words, when the radiograph, the X-ray, can penetrate a substance, you will see it as dark. When it can't penetrate, then you will see it bright. So, in other words, bone you will see as what? As light, but then, I mean, the technique, radiography, the best radiography technique is what? Is paralleling technique. Long cone paralleling technique. Why? Because we want to see the relation of crest of the bone to the CJ. Now, if you bisect the angle, you won't see that. Now, I do have 3 more minutes, so let me see what else it goes down. Now, okay, so early changes in bone, you see fuzziness in crest of the alveolar bone. Then widened PDL, you will see horizontal bone loss. How you decide whether there is horizontal bone loss? You connect 2 adjacent CJ, and in the proximal area, you can determine whether horizontal bone loss or not. If it is more than 2 millimeters from CJ, then you know that there is some kind of bone loss. Also, if you see fuzziness in the crest of the alveolar bone, you know that there is bone loss. So, in other words, what you see on the X-ray is bone. You can't see bone loss, but you will determine whether it is bone loss or not. Now, this doesn't want me to go. Now, bone defect also you see on the radiograph. About implant, also peri-implant bone loss, you will see like that. Now, this doesn't go. Now, can I use something else so that I go forward? Now, triangulation, when you see funneling of PDL. In other words, at this area, you see funneling of PDL. It is called also triangulation. It is because of bone loss, but bone loss because of what? Because of pressure, and not because of infection. It is inside the periodontal ligament. You will see widened PDL. Why you see widened PDL? Because you have bone loss. But bone loss is not because of infection in that case. It is because of pressure. So, now, let me see if I can show something else. Otherwise, I think in 1 minute we will be done.
I think you probably should go back and review radiographs with them
basically,
next
basic
week.
things, I talked about that. You just go over
that
that.
might be
These are
best.
all the things which you need to review that. Now, if you have any question, let me know. You know that not next week, the following week you do have midterm. So go over this lecture. If you have any question, let me know. Okay? And have a good rest of the day. So I finished right on
She's
time.
got a question.
Yes.
Responsible for the rest of the slides?
The rest of the slide is just explanation of radiographic findings. Yeah, somehow you are responsible. But the basic thing is that you should know that you can check bone loss. You know that on the X-ray you can see just bone. You can't see bone loss. You interpret that there is bone loss. Okay, and then you should know that widened PDL. So the important thing are these things. In other words, if you don't want to go over the rest, it's up to you. But know the basic things, which is what the most important is: bone loss, and then widened PDL, then defect, why we do how, the kind of bone loss which will be what? Horizontal bone loss, vertical bone loss, you should know that. Vertical bone loss is when there is more bone loss on one side of the tooth. Then you do have vertical bone loss. So these are the main things. Now you have lots of other things which I think for the purpose of exam, you should know the basic thing. And then it might, because it is for multiple choice question, it might come, but the main thing is very. Any questions? Yes. Say that again. Oh yeah, at the end of this one, I put the pertinent things which I covered.
The topics. You just put the topics.
And the next one also I will get the topics. Okay? Okay. So anyhow, I didn't know that you like study guys, but I put
You
yes.
did it a little different because it's
Yeah.
mostly the topics. It's not the information.
Yeah, that's the point.
So
So I will remove. Did you remove it? Remove it. Thank you.
I have a quick
Thank you very much. Yes, go ahead.
So one of the questions on the quiz
Yes.
just asked, it was 4 statements about, do you know the quiz? Okay. It was about what affected the periodontium or what didn't, and it said males that are higher
Yes.
have higher prevalence, which is true.
Yes.
But then it said smokeless tobacco has no effect on the periodontium. And so then on the slide, I picked that it says both tobacco and smokeless tobacco.
Yeah, that's wrong.
It's wrong.
That's wrong. Because smokeless tobacco is the same as tobacco, has effect on.
Yeah. And then I selected it said.